when you think about health workforce, you need to think about the full value chain. So as a country, the first thing we actually do is think about what are the needs that we want, and we are thinking about planning and the people entering into the pipeline. And they get into training. So that's how they are prepared for the workforce. After they've gotten through training, they get into registration. And once you're registered and you want to practice, you are licensed. And that then forms the stock of the healthcare workforce that is ready to serve. The next level then is deployment. So there are different pathways to this. There are those who go in the private sector, there are those who go in the public sector. And we also have some who drop off along the way. We put them in a category called underemployed. And then last but not least is issues of exit, including programmed exit through bilateral labor agreements. But also we have a lot of health workforce who are leaving through independent channels supported by agencies. We'll hear from the panel when they are discussing what happens when donors move out.
The issue of Trump stop work order, and then the impact, the boomerang effect on all donor-funded projects. And the truth of the matter is that it caught us pants down. However, right alongside that conversation, when the stop order came, it meant that there are people who are not going to be able to report to work. And so subsequently, there's been attempts at adjustment within that space. It's been a very tough journey integrating. And the reason is because things run in projects very different. The pace, the agenda, the objective, the strategies that work within projects is more private sector oriented. And that's very different from how public sector works. Public sector is a little more diffuse and people get deployed differently. The framework for job specifications and job descriptions is very fluid.
It's one thing to hire, and that's what mainly we see. But it's another thing to have the systems in place, because when you have a strong system, then you can absorb the shocks that came through when the stop work order came. Unfortunately, with the change of government and the coming in of the President Trump, there was a reduction in foreign aid support, and this called for a reduction in support that were given to health workforce in Kenya. And it's unfortunate because that actually created what we call program injury.
In terms of transition in donor support in the health sector, I would say it got us flat-footed. We expected, and there were discussions around transitioning, but we didn't expect it to come that fast. So I think for now we have some interim arrangements for those systems. They are still running, they are not totally down, but we actually need to sit and have a hard talk on continuing and the sustainability of those systems. You actually realize some areas were totally being supported by donors, and with their withdrawal, you find you have none in that position, and you have to make very urgent plans because it has to keep running. We also realized that the donors were very generous with their pay to the workers. When they were let go, we could not just take them at the salaries at which they were going.
What we've seen is when we've sent for job adverts, we are getting more skilled people coming in, higher skilled people coming in and looking for opportunities. And that what it does, then there are two things. One, perhaps that's a silver lining, one might say, is that they're now available for work in the private sector, and hopefully we can then borrow or buy that skill that they have built in the programs that they were working in. But secondly, it's something that Prof had mentioned around a governance structure for deployment of healthcare workers. What would be the standard skill set for certain roles, so that when an issue like this happens, then it's easier to absorb those who are now free for work, because it's very clear how they fit into the structure in private sector.